We are from RG Stone Hospital. We would like we would like to introduce our doctor, senior most urologist, Dr. Barun Shah, MBBS, MS, MRCS, and MSH Euro. So I would like to invite Dr. Sir to have a lights on kidney stone management.
Thank you. Thank you very much. I think today, after a very hectic day, all of you are very fatigued right now, and it will be very comfortable you to get me into the matter in a very lucid way, not very theoretical or not very in depth of the matter. As such, kidney stone disease, if we want to discuss it elaborately, then it will take too much long time. I will give just an overview of this topic. Uh, Shubhashis? To introduce, I would like to get your attention that it is one of the most common affliction of today's modern society due to the food habit or water intake, different lifestyle, obesity. Today, thank you.
হঠাৎ আমার চোখ গেল ওই দিকে
So, if we look at the global prevalence of the disease, we can find that lifetime prevalence of this kidney stone disease ranges from 1 to 15%. And the peak age of stone disease varies in males and females. In male, it is most common in younger age group, mostly 30 to 60, 70 years of age, and in female, ranges from 50 to 79 years age. Basically, in female, we see two bimodal distribution, one at the younger age group and one at the later 70, 75 years age. Next slide, please. So, if we look at the epidemiology, and it occurs mostly in patients with previous urinary calculi. It is more common in male as compared to female. It is approximately 2 to 3 times more common in male. Occurs in adult male more common than elderly, and it is seldom found in children. Although it is occurring today more commonly in children, but it is the incidence is more in adult age group. Whites are affected more often than persons of the Asian ethnicity, and Asian ethnicity populations are more affected than the black. Next slide, please. Higher prevalence is being noted in hot, arid, and dry climate. Next slide, please. Next slide. Basically, the main underlying pathology because why kidney stone occurs in hot, arid, and tropical countries like India, Pakistan, Bangladesh. The reason behind when there is more hot and warm weather, there is relative dehydration in the body, so the urine become less in amount, and urine as a solvent dissolve the compound. So as the solvent become less, there is more chance of concentration of the salt and the stone formation. Global epidemiology, you can see the red marked area. It is mostly in the African, sub-Saharan hot arid climate and tropical countries like India, Bangladesh, Pakistan. Here the incidence of the stone is very much common. We can also see that in the USA, the southern USA and Mexico surrounding that part, they also due to this same tropical atmosphere, they have also increased incidence of stone disease. European countries and rest of the USA also has higher incidence of stone disease marked as a yellow line. Next slide. So now come to the what are the types of renal calculi. The majority of the renal stones are calcium containing stones, and predominant stones are calcium oxalate. Then there are some other stones. 80% of the stone are calcium containing stones. 15 up to 15% of the stones are infected stone or struvite stone, and 5 to 7% stones are uric acid stone. These three varieties are the most common varieties of renal stone. Apart from these, there are certain other types of stone like cystine stone, Indian stone. These stones are rarely found 1 to 3% of cases. Next slide, please. So, in a very short nutshell, how the stone forms. When there is a saturation of the solute inside urine, there is equilibrium between the dissolved component and the diluted component. And when further solute is being added to that saturated component, there is supersaturation of the solute. Then there is crystal liquefaction, and gradually there is aggregation of crystals, and later on over the crystals, solute deposits and the stone increases in size. Next slide. So, what are the diagnostic evaluation? So, we must identify associated metabolic disorders that are responsible for recurrent stone disease. We should take proper history to find out what are the medications. Is there any medications history which patient is taking, like someone is taking calcium for a very long time, calcium carbonate, these sorts of medications can predispose stone formations. We should find out what are the dietary excesses, inadequate fluid intake or excessive fluid loss. Like in chronic diarrhea, there is a lot of fluid loss inside from the body, so there is some difficulty in absorption of calcium or oxalate. There is imbalance in calcium oxalate absorption, and stones are more commonly found in these sorts of IBS or chronic diarrhea patients. Next slide, please. What are the indications of metabolic evaluation? We generally don't suggest metabolic evaluation for each and every individual which comes with a history of renal stone or first time stone former. But there are certain conditions where metabolic evaluation is being recommended, like strong family history of stones, recurrent stone formers, intestinal disease, particularly chronic diarrhea, solitary kidney, where there is only single kidney, but single kidney having stone is a very critical situation, so tackle on. Renal insufficiency or chronic kidney disease and anatomic abnormalities. In these cases, we suggest metabolic evaluation. Next slide, please. Multi-channel blood screen is being advocated. Apart from basic metabolic panel like sodium, potassium, chloride, carbon dioxide, we also suggest calcium, intact parathyroid hormone, and uric acid level estimation. Next slide, please. Urine analysis is the most important feature. In urine, we usually assess the pH of the urine. In alkaline pH more than 7.5, usually infectious stone or struvite stone forms. Whereas in acidic pH, in urine pH less than 5.5, uric acid stone predominantly develops. In urine culture, if we find urea spreading organism, we must think of infectious stone. Next slide, please. From microscopy stone analysis also, we can have an idea of the type of the stone. We can, here there are some pictures, like at the right hand bottom corner, this is a hexagonal crystal. So from seeing the hexagonal crystal, we can say this is a cystine stone. Like in the left hand bottom corner, there is a envelope shaped stone. This is struvite stone. Calcium oxalate stones are typically the left hand upper corner is a typically pyramid shaped or dumbbell shaped stone. So we can have an idea from the microscopy what are the basic stone formation inside this particular individual. Next slide, please. So after the metabolic evaluations and basic urine analysis, basic blood test, we come to the more confirmatory test to identify what are the site of the stone, what is the size of the stone, and what is the composition of the stone. So now comes to the radiological investigations. Among the radiological investigations, there are various sort of investigation. Previously, we have had only X-ray tube in our hand. It is nowadays also most commonly done imaging. It is a very helpful imaging for follow up. It also helps to identify the initial size of the stone and presence of the stone, but it is the most important to follow up with patients with the X-ray to see whether the patient has stone free clearance or not. Next slide, please. Intravenous pyelography or intravenous neurography was previously randomly used, and it is very easy to interpret for urologists to identify where is the exact site of the stone or what is the exact obstructive features of the stone. But nowadays, with the advent of CT scan, the use of intravenous pyelography has been reduced. But still, today CT is not commonly available in everywhere in the part of the Bengal. So IVP plays an important role. Next slide. Ultrasonography has a certain advantages, like it has no radiation exposure, can be done in pregnant female also. It detects radiolucent stone. The radiolucent means that type of stone which is not being picked up by X-ray tube. It can use an adjunct in ESWL. In ESWL, we can focus the stone with ultrasound guidance. So it is a very helpful tool for our TB stone management. Next slide. But the limitation is the ultrasound cannot detect very small size stone. CT urography is the investigation of choice in the imaging of kidney stone disease. It has a sensitivity and sensitivity more than 95%. It also gives information regarding the composition of the stones. It confirms the diagnosis in which USG is equivocal. Next, MRI is seldom used for renal stone disease. It is done only when CT is contraindicated. Next. Next. So we now come to the treatment purpose. Treatment, initially we advise conservative treatment and medical treatment. In conservative treatment, we advise all the patients regardless of the underlying etiology of the stone. Calculi less than 5 millimeter usually pass out spontaneously with medications and with oral hydration therapy. Yes. Fluid recommendations. Patients is often asked what should the ideal fluid intake for me? How much fluid I can take in a day? We always respond in a matter that how much fluid you should take is a relative matter depending upon your occupational occupations and depending upon your work place of work. But you should always try to have a urine output of around 2.5 liter per day at least. That is the target urine output. For that, if you have to take 3 liter of urine, you are a person who always stays inside the room with AC on. So for producing 2.5 liter urine, hardly have to take 3 liter of water. But you walks in a you goes outside home in a bus or train or in public vehicle. So then in that matter you have to take 4 liter of water for to produce 2.5 liter of urine. And if you work in a field job, you do a field job, then you can have to take 5 to 6 liter of urine water to produce 2.5 liter of urine. So your target should be at least have 2.5 liter of urine per day rather than fetching for how much water I should take. Dietary recommendations, we usually advise to minimize animal protein intake, especially red meat and eggs. We advise to take less animal protein. You can take small fishes, but try to avoid large fishes, 5 to 6 kg size fishes. Red meat, especially mutton and eggs. These are animal protein we advise to reduce. We also advise to avoid sodium salt addition in food out apart from the salt required to cook the food, and some there are some selective medications to prevent stone formations like thiazide as the one group of drugs. They usually increases the calcium absorption from the proximal tubules, so there is a decrease in the calcium in the urine overall, and they helps to prevent calcium stone formations. Potassium nitrate is a stone preventer. They dissolve some small stones. They have to prevent stone formation and dissolve some small stones. And allopurinol is a drug only helpful for uric acid stone. They decreases the serum uric acid concentration, thereby helping to prevent recurrent uric acid stone. So after in short, the medical therapy, I would like to highlight in a short what are the advances in surgical technique in to tackle renal stone disease. Today, in the modern era, we seldom do perform the open surgical procedures. All of the stone, how much size it matters, doesn't matter. We do minimally invasive surgeries. We have in our armamentarium percutaneous nephrectomy, extracorporeal soft lithotripsy, retrograde internal surgery. and laparoscopy and robotic stone surgery. Although we are talking about this minimal invasive surgery in certain part of the country, still today open surgery is being performed, and I would like to highlight some of the open surgical procedures. Next slide. Like nephrolithotomy, pyelolithotomy, and extended pyelolithotomy. Now, I will, in very short, I will just elaborate the microsurgical techniques. Next slide. Percutaneous nephrolithotomy, as in the picture you can see here, the percutaneous access is being made inside the kidney from skin. We make an entry into the kidney through a small hole, and through that small hole we passes a nephroscope. Through the nephroscope, certain energy is being delivered over the stone, either being laser energy or pneumatic energy. The stone is being fragmented and being removed from the kidney in pieces, or through the water jet it is being removed. Next slide, please. It is preferred for stone size of more than 2 centimeter in size. Stab on stone, that means the stone is being present in all the cases of the kidney. Hard stone that are not being amenable to by GSWL, and urinary obstruction that need correction. In this scenario, percutaneous nephrectomy is the first option. But it has certain complications and next slide, please. Like acute and delayed hemorrhage, as we are puncturing the kidney and we are making a hole inside the kidney, so there is always chance of hemorrhage. It may lead to collecting system injury, visceral injury, pleural injury, and metabolic and physiologic complications. Next slide, please. Post-op fever, sepsis, neuromusculoskeletal complications, venous thromboembolism, tube disorgan, collective system obstruction, loss of renal function, and even death has been reported in PCML. Next slide, please. Now coming to the next model of therapy, that is a shockwave lithotripsy. We usually say extracorporeal shockwave lithotripsy or ESWL. Here, an ultrasound shockwave is being provided over from the surface of the body inside the kidney by through a ultrasound imaging modality, and the stone is being fragmented into smaller pieces, and that is being easily passed through the ureter. Next slide. Indicated success depends upon the efficacy of the lithotripsy and following factors like size, locations, and composition. Patient's habitus, it is not suitable for patients with very obese. In that scenario, the energy level which is delivered on the surface of the skin is not properly transferred up to the stone's surface. So the very large and obese patients are not suitable for DSW. Next slide, please. Content. Yes, right. Contraindication of the extracorporeal shockwave lithotripsy like pregnancy, bleeding diathesis, which should be compensated for at least 24 hours or before and 48 hours after the treatment. Uncontrolled urinary tract infection, severe skeletal malformation, severe obesity, arterial aneurysm in the vicinity of the stone, and anatomical obstruction distal to the stone. These are the contraindications of DSWL. Now coming to the most advanced technique. Next slide. Ureteroscopy and flexible ureteroscopy. Next slide, please. The upper image is the image of semi-rigid ureteroscope, and the lower three images are the image of flexible ureteroscope. Next slide, please. Here we can pass a ureteroscope through our normal urethra through the bladder, and then we can negotiate the ureteroscope inside our ureter, and in ureter we can see the stone under our vision, and then we can fragment the stone with the help of the laser energy, and the stone is being fragmented into smaller pieces, and then we can hold the stone with the basket and we can take it out. When this procedure is being performed inside the ureter, it is called ureteroscopy, and when this procedure is performed inside the kidney, it is called RIRS or retrograde internal surgery. So the indications being the failed ESWL, RIRS assisted ESWL, radiolucent stone which is not being seen through the X-ray images, calcium diverticular stone. Used in patients with ESWL contraindications like bleeding disorder or patient was on anticoagulant, obesity, pregnancy. Next slide. The complications being sepsis, strain stress, stricture, urinary injury, urinary tract infection, etc. So to conclude, the diagnosis of nephrolithiasis is often made on the basis of clinical symptoms alone. All the confirmatory tests are usually performed. Medical treatment of nephrolithiasis involves supportive care and removal of risk factors. Stones of less than 7 millimeter, stones that are more than 7 millimeter are unlikely to pass spontaneously and require some types of surgical procedure. Thank you. I'd like to have questions from you.
এই মাইকটা ওদিকে দেখে ওদিকে কিন্তু শুনতে ফার্স্ট লাইটটা করে দাও ফার্স্ট লাইটটা করে দাও ফার্স্ট লাইটটা করে দাও হ্যাঁ তোমার এই কোশ্চেন
In most of the cases, it has been seen that in USG, the stone is not detected. Either it is in case of your gallbladder or kidney. Most of the cases, either the patient has to go through MRI, or in case of gastroenterology, MRCP. So, is it really required to do USG, or directly some patients say we should go through the MRI or CT scan?
I am very happy to have a questions like this. And I will answer one by one. Look, USG is a basic diagnostic tool. It is also called a surgeon's stethoscope. So, whenever a patient comes with a pain, abdomen sort of feature symptoms, so the role of USG always remains there. It helps to localize the site of origin of the pain. Whether the pain is originating from gallbladder or whether the pain is originating from intestine or originating from kidney, it helps to localize the site of pain. Apart from localizing the site of pain, it also gives some information of the basic diagnosis. Suppose as you have already said, it is very common that we find that there is no stone in USG, but we found in the CT. But ultrasound always give a clue that there might be something in ureter or something that we have missed. Ultrasound, due to the presence of bowel shadow, gas shadow, sometimes can't detect stone pretty accurately, the location of the stone or size of the stone. In that cases also, the ultrasound detects there is a hydronephrosis or swelling inside the kidney. So from that picture, we can guess that something there is obstruction in the urinary lumen, and we have to go for a CT. So ultrasound guide us whether this is the site of origin of the stone. And if we find a pain of the patient on ultrasound there is a stone inside the gallbladder, then we will not do CT for kidney. We then recommend MRI or MRCP for gallbladder origin. So to narrow down our vision or narrow down our imaging spectrum, we need ultrasound. And ultrasound most easily available diagnostic tool in all over the any part of the India. It's most easily available tool. So ultrasound is a very basic important tool. Still holds its position.
Apart from that, is there any symptoms from which someone can understand that he is might getting affected the kidney stone? So, there any from the any symptoms or by the color of the urine?
The most common symptom of urolithiasis is the pain. Pain. The pain usually is located in the flank. The flank is on the back side, upper back side. The pain is in most of the part in the flank, and sometimes it is a radiating pain towards the lower abdomen. This is the most common symptom. Apart from the pain, there might be presence of blood in the urine, or this is called hematuria. There might be urinary frequency or dysuric symptoms, and sometimes there may be symptoms of fever or of intestinal or obstruction related symptoms like vomiting, nausea, vomiting. These are the symptoms for retinal stone. Initial symptoms.
So the patient will be processed with whether there is presence of occult blood or RBC.
Patients usually can't see
No,
RBC in the urine.
Yes.
What they see is the reddish color of the urine. That is called gross hematuria. Microscopic hematuria is something else. when you do a urine report and there will be RBC in the blood urine report. That is called microscopic hematuria. Microscopic hematuria, patient can understand. Patient can understand a gross hematuria where he or she can see reddish tinge in the urine. So that before that, she sometimes he or she may not feel, but usually it is accompanied by a pain in the flank.
And most of the cases it has been observed that the females are often affected by the urinary infection. Is it because of the physiological change from the male and female or something related to female?
No, it is absolutely due to the physiological changes of in male and female. Female has a short urethra, no, they don't have a penis, so there is a another natural orifices, vaginal orifice, and the anus is very close proximity to the urethral orifice, and due to the absence of the absence of any male like body part that is easily access to the urethral lumen from the anus, the fecal contaminations, and from the vagina during the menstrual cycles, there is contamination of the urinary stream. So there is more chance of urinary infection in females due to these anatomical changes.
And the first process which you have shown apart from the open surgery is that to break the stone inside the kidney. So is there any process like ERCP like in gallbladder
Basically,
by which the stone that can be removed?
basically, we have to understand why the stone is not being passed. It is not being passed spontaneously because of the size of the stone. So until and unless you make it smaller in size, how it can be removed?
So and you shown on bucket system by which that can be
that is only after fragmentation of the stone. Suppose the stone is of 7 or 8 mm size, we have to fragment it and the smaller pieces then you can remove with the basket.
So that is both for male and female.
Yes,
The process can be
that's the same. Only the negotiation up to the urinary bladder is different in male and female. In male, it is a 20 centimeter long urethra, so the negotiation up to the bladder is little challenging. In female, it is shorter urethra. Apart from that part, everything is same.
Last question, economical question. Whether WHS is available in your RGS hospital?
This the RG correspondent will answer that.
WBCS আছে তো আপনার?
WBCS
Actually, he is a professor of mechanical engineering department.
Okay.
He recently diagnosed with a stone and he has to operate recently, very recently.
Okay.
He has done in separate hospital,
Okay.
but he has live experience on the matter. So he raised the point.
No issue. You can avail the both, the Jadavpur University Mediclaim also and the West Bengal Health Scheme also.
Okay.
What will be the convenient for you? Any more questions? Yeah.
I mean, after
বাংলাতে বলবো সবাই বুঝবে সুবিধা হবে।
মানে ঘটনাটা ঘটে গেলে তো আমরা আপনাদের কাছে যাবো ডাক্তারের কাছে যাবো আমি এখন প্রিকশনারি মেজার্স and any gender issue আছে কিনা মানে আমি একটু রেটে ঢুকেছি তো সেই জন্য
Gender ratio we already বলেছি স্লাইডে males are more prone to develop renal stone than female. The average ratio is 2.3:1 male is to female ratio. And prevention এর জন্য কি করতে পারি? Prevention এর জন্য যেটা আমাদের মোস্ট ইম্পর্টেন্ট adequate fluid intake, খাবারে এক্সট্রা সল্ট নেওয়া যাবে না এবং অ্যানিমাল প্রোটিন স্পেশালি রেড মিট এগস বড় মাছ তেল চর্বিওয়ালা বড় মাছ এগুলো অ্যাভয়েড করা
ভালো মাছ না গেলে মাছ খাবো ঠিক আছে থ্যাংক ইউ
Any more questions?
সামগ্রিক মধ্যে রেস্ট্রিকশন
Sir,
বড় মাছ বিক্রি
সামগ্রিক মধ্যে রেস্ট্রিকশন
Thank you everybody. Be a part of this such a nice talk. Thank you, Patrak sir.
একটু হাসপাতালের সম্পর্কে একটু ব্রিফ করুন।
Okay. Our hospital, Ajishun Hospital, it's a urology hospital, and we also have a general surgeries and ortho surgeries and gynae also. We have around 14 branches in all over India. Okay. So this is a legacy of 36 years of our hospital, Ajishun Urology. It's a head office in Delhi. We have and we have a Guinness Book of World Record of the kidney stone and also the prostate also. Okay, so any kind of you can go for the surgery related to kidney stone or the hernia, gallbladder stone, okay, and also for the general surgeries like orthopedic, okay. So you can always welcome, you can come down to our hospital. We have a good number of surgeons are attached in Kolkata. Some reported surgeons are attached with our hospital, and it's very nearby to your place from your university also. Most of the people from your university also have taken our services, and hope so the feedback was good. But next I will give you the feedback. আচ্ছা বলছি সবাই মানে অনেকজন হয়তো এই হসপিটালে আমাদের সম্বন্ধে জানেও ইউনিভার্সিটি থেকে। আমরা এর আগেও এখানে একবার এসেছিলাম কথা, আর এখান থেকে অনেকজন সার্জারিও করেছে কিডনির উপরে, স্যাররা জানে ফিডব্যাকের উপরে। আমাদের হসপিটালের এক গ্রুপের নিচেই ইউরোলজি, আপনার হার্নিয়া, জেনারেল সার্জারি, অর্থো, গাইনি সবকটাই হয়। মানে ইউরোলজি রিলেটেড কোনো জিনিসে আপনি আমাদের হসপিটালে যেতে পারেন।
It is convenient and closer to Jadavpur University.
Yes.
Many may not know, na?
Right.
Yes, that location.
The location is the hospital. It's not a kilometer also. It's very nearby. It's a 500 meters from your Salimpur mall. Okay. So through picking means side, and rest of the things we are not saying that's a welcome to in our hospital. If anybody needs any kind of services, is always welcome to our hospital. They will give every treatment in our hospital. Okay. Thank you. I will pass on the mic to Patnaik sir.
আজকে আসলে ওয়েদারটা খুব খারাপ, আমাদের অ্যাটেন্ডেন্সটা একটু ঠিক। আমি প্রথমে ডাক্তারবাবুকে ধন্যবাদ জানাই এবং স্পেশালি আরজি স্টোন হাসপাতাল যে কর্তৃপক্ষ তাদেরকে ধন্যবাদ জানাই এরকম একটা অনুষ্ঠান উপহার দেওয়ার জন্য। আজকে সারাদিন মানে সকাল থেকে একটা ব্লাড টেস্ট এবং চেক আপের ক্যাম্প ছিল। আমরা 100 জনের একটা এস্টিমেট করেছিলাম, আমিও সুভাষিস করেছিলাম কতজন কি করতে পারবে। সুভাষিস করেছিল 100 জন মতো যদি হয় স্যার আমরা করতে পারি। তো আমরা নোটিশ করেছিলাম, সবাইকে যতজনকে পারানো জানিয়েছিলাম, কিন্তু ফাইনালি দেখা গেল আমাদের 52 জনের মধ্যে ব্লাড নেওয়া হয়েছে, যেটা বললো 58। তো ফাইনালি মানে উই ক্যান রিচ 100। সো ইট ইজ আওয়ার ল্যাক। সো আই থিঙ্ক ইন দ্য নেক্সট ফিউ কেসেস উই শুড রিচ দ্য টার্গেট। একটা ফ্রি ব্লাড টেস্ট এবং ফ্রি চেক আপ ক্যাম্পে আমরা 100 জন লোককে হাজির করতে পারলাম না, যেখানে আমাদের এখানে অন্তত 1000 লোক প্রত্যেকদিন ঘোরাফেরা করে। এটা অ্যাকচুয়ালি একটু অসুবিধা বলে আমার মনে হয়েছে। নিশ্চয়ই ভবিষ্যতে আমরা খেয়াল রাখবো। আর ডাক্তারবাবু যেটা বললেন, ডক্টর বরুণ দাস সাহা খুব ভালোভাবে ব্যাখ্যা করলেন। এই স্টোনটা আসলে আপনারা সবাই আমরা জানি, হঠাৎই ধরা পড়ে তখন অ্যাগ্রাভেট করে যায়। এটা হচ্ছে সমস্যা। অ্যালার্ট থাকা, কিছু চেক আপের ব্যবস্থা করা, এগুলো করতে হবে। আর আরজি স্টোন নিয়ে যেটা স্পেশালি আমি পার্সোনালি বলতে পারি, আরজি স্টোনের খুব ফ্রেন্ডলি অ্যাটিটিউড, ছোট্ট একটা জায়গা, কিন্তু তাদের ম্যানেজমেন্টের খুবই কর্ডিয়াল রিলেশন আমাদের সাথে। যে কোনো কেস আমরা পাঠাই, ওরা খুব গুরুত্ব দিয়ে দেখে, খুব তাড়াতাড়ি করে দেয়। ডব্লিউবিএইচএস রেটে করে দেয়। যাদের ধরুন মেডিক্লেম নেই, আমরা এই যে ক্যাম্পগুলো করছি, এটা তো শুধু যারা মেডিক্লেম আছে তাদের জন্য তো করছি না। আমাদের এমপ্লয়ীদের অনেকেই আছেন যাদের মেডিক্লেম নেই, তারা কীভাবে ট্রিট করবে? তাদেরকে আমাদের যাতে একটু সস্তায় হয়, একটু ভালোভাবে হয়, সেটাও আমরা অনেক সময় রেকমেন্ড করি। এবং আমি গ্ল্যাডলি কিন্তু আর্টিস্ট এটা করে দিয়েছে। কাজে এইগুলো ওদের খুব ভালো দিক আছে। এবং ওরা একসাথে তলায় যেটা বললো, সমস্ত ফেসিলিটি আছে, গেলে সঙ্গে সঙ্গে রেসপন্ড করে। আমি পার্সোনালি বেশ কয়েকবার গেছি বিভিন্ন পেশেন্টকে নিয়ে, আমি দেখেছি খুব ভালো ব্যবস্থা। সেই কারণে এটা যেহেতু খুব কাছে, আমার মনে হয় এই যাদবপুর প্রক্সিমিটিতে অলমোস্ট 50% অফ আওয়ার পপুলেশন resides in 2.5 kilometer of radius from Jadavpur University. So we can avail this hospital as a special case. We can reach there. এবং আমি যেটা আপিল করবো এর কাছে, সুভাষিসের কাছে, অন বিহাফ অফ ম্যানেজমেন্ট, ইউ জাস্ট টেক আপ দ্য ম্যাটার, যে যাদবপুর ইউনিভার্সিটির লোকরা গেলে যাতে একটা আউটডোর ভিজিট বা এইগুলোতে কোনো স্পেশাল প্রেফারেন্স পায় কিনা সেটা একটু এক্সামিন করে বলো, যাতে আমরা এটাও পাবলিশ করতে পারি যে যাদবপুর ইউনিভার্সিটি পেশেন্ট গেলে সে একটা কনসেশন পাচ্ছে কি, সেটা প্রায়োরিটি পাচ্ছে, প্রেফারেন্স পাচ্ছে। এইটা বা যার মেডিক্লেম নেই, স্পেশালি যার মেডিক্লেম আছে সে তো কাভার্ড আছে, সে পেয়ে যাবে। কিন্তু আমার একটা গ্রুপ অফ এমপ্লয়ি, ধরুন আমার এমপ্লয়ি এবং পেনশনার মিলে আমার পেরোলে 4000 লোক আছে, 4000 লোকের মধ্যে কাভার্ড আছে 1700, তার মানে কিন্তু 2300 কাভার্ড না, এটা মাথায় রাখতে হবে। 2300 হেডস অ্যালং উইথ দেয়ার ফ্যামিলিজ। কাজে এই জায়গাটা তাদের জন্য আমি এটা করছি এই কারণে যে তারা যারা মেডিক্লেম কোনো কারণে করতে পারেনি, মেবি ফিনান্সিয়াল গ্রাউন্ডে, মেবি সাম ফর আদার প্রবলেম, তারাও যাতে একটা সস্তায় চিকিৎসা পায়, ভালো কোয়ালিটি ট্রিটমেন্ট পায়, এটা ইনশিওর করার আমাদের দায়িত্ব। কাজেই স্পেশালি যাদবপুর ইউনিভার্সিটিতে আমাদের নন টিচিং এমপ্লয়িরা যারা মাস্টারমশাই অফিসার, আমরা অ্যাওয়্যার, আমরা এদিক ওদিক কিছুটা ম্যানেজ করে নেবো, কিন্তু আমি বেশি কনসার্ন নন টিচিং এমপ্লয়ি এবং পেনশনার আমাদের যারা, তাদের ইনকামটা একটু কম, তাদের বেনিফিটের জন্য আমি বিভিন্ন ব্যবস্থা করেছি। আপনারা জানেন যে সুরক্ষার সাথে টাই আপ, মেডিনোভার সাথে টাই আপ, কনসেশনাল ট্রিটমেন্ট মানে টেস্টগুলো করেছি, পিয়ারলেস এর সাথে কনসেশনাল ট্রিটমেন্টের ব্যবস্থা করেছি। রিসেন্টলি আমরা একটা ক্যান্সার হাসপাতালের সাথে কনসেশনাল ট্রিটমেন্টের প্ল্যানিং করছি, এগ্রিমেন্ট করব। এই সমস্ত বিষয়গুলো করছি আমি ওভারঅল মাথায় রেখে যে যে সমস্ত আমার এমপ্লয়ি এবং পেনশনারদের মেডিক্লেম কাভার নেই, তারা যাতে বেনিফিট হন, তাদের 2 পয়সা বাঁচে। তো আশা করবো আগামী দিনে এরকম উদ্যোগ আরো সফল হবে। আর আরজিস্টন হাসপাতাল কর্তৃপক্ষকে অসংখ্য ধন্যবাদ, শুভাশিসকে ব্যক্তিগতভাবে আমার ধন্যবাদ, যাতে এরকম আরো আমরা প্রোগ্রাম করতে পারি। উদ্যোগটা খুব ভালো হয়। আর কোনো সমস্যা হলে আমাদের ডাক্তার ম্যাডামের সাথে ডক্টর মিতালি দেব রয়েছেন, যোগাযোগ করো। উনিও রেফার করেন, ওনার কাছে এলে উনি তো রেফার করেন, সেইভাবে যোগাযোগটা রাখবে ওনার সাথে। উনি আমাদের এই ওয়েলফেয়ার কমিটির একজন সদস্য। আর আমার মাস্টারমশাই এখানে আছেন, দীপকবাবু, গোপীনাথবাবু এবং পার্থবাবু ছিলেন, বেরিয়ে গেছেন। তারা সবসময় পার্ট এন্ড পার্সেল অফ আওয়ার টিম। তারা আমরা ইংল্যান্ডের মধ্যে কাজ করি, আমার ওয়েলফেয়ার ইউনিট আছে এখানে। সবাইকে ধন্যবাদ জানাই। আজকের অনুষ্ঠানটা আমরা শেষ করছি।
Thank you, sir.